Welcome to Chapter 17, Communication and Documentation, Emergency Care, 14th edition for the EMT. So we're going to talk about all these things: the verbal report, interpersonal communication, the pre-hospital care report, special documentation issues, and communication systems and radio communication. So let's talk about that first. So EMS radios consist of base stations, mobile radios, portable radios, repeaters, cell phones, telemetry, all those things. New technology developing almost constantly, computers and tablets as well, backup radios in many systems, and radio systems require preventative maintenance and repair. So let's talk about the dispatch, how things go. So somebody calls 911, the 911 dispatcher gets on the radio and sends it to a repeater. That repeater then goes to portable radios, base stations, various other things to send out to the mobile units and everything like that. So you kind of have to have a repeater, especially out in the rural areas. Radio communication is regulated by the FCC. It assigns and licenses designated radio frequencies. It prevents interference with emergency radio traffic and prohibits profanities and offensive language. There have been lots of things heard on the radio. Lots of cuss words, lots of inappropriate things, lots of sex heard on the radio. So just be aware with an open mic. Recently I was listening to, I had my radio on scan and I heard one of the deputies talking to his wife on the phone. He had an open mic and he was talking to his wife on the phone about their trip, and then they got to joking, and it didn't get quite explicit, but you kind of got the gist of what they were talking about. So follow these simple rules when using the EMS radio system. Make sure that your radio is on and the volume is adjusted properly. Reduce background noise. Listen to the frequency and ensure that it is clear before beginning a transmission. Press the push to talk button on the radio and wait 1 second. I typically tell people take a breath and then speak. Speak with your lips 2 to 3 inches from the microphone. When you're calling another unit or base station, use their name, unit number or name followed by yours. So dispatcher, this is ambulance 2. It kind of goes back and forth depending on the service that you're with. Some people do 402 Camden County, or some people do Camden County 402. It just kind of depends on the person, really, and the service. So if the unit you're calling tells you to stand by, just wait until they are ready to take your transmission. Speak slowly and clearly. Keep the transmissions brief. If it takes longer than 30 seconds, stop at that point and pause for a few seconds so emergency traffic can use the frequency if necessary. Use plain English and avoid 10 codes. Do not use phrases such as be advised. These are implied and serve no purpose. Courtesy is assumed. There's no need to say please, thank you, and you're welcome. I do it. It's just something that you do. When transmitting a number that might be unclear, 15 may sound like 16 or 50. Give the number and then repeat the individual digits. Say 1515. I do that when I give ages. When I give radio report to the hospital, I'll say, I've got a 70-year-old male, 70-year-old male patient with blah, blah, blah. Anything said over the radio can be heard by the public on a scanner. Do not use the patient's name over the radio. And for the same reason, do not use profanities or statements that tend to slander a person. Use objective and impartial statements. Use we instead of I. As an EMT, you will rarely be acting alone. Affirmative and negative are preferred over yes and no because the latter are difficult to hear. Give assessment information about your patient, but avoid offering a field diagnosis of the patient's problem. Which, in some cases that's fine. In other cases, like patients that are having a stroke, okay? If the patient is having a stroke and you are 90% sure that it's a stroke, holler on the radio, say, hey, I'm coming in with a stroke, okay? Because when the hospital hears that you're coming in with a stroke, then there are things that they're going to activate. There are things that have to be activated inside the hospital in order for that patient to get the best care. Avoid slang or abbreviations that are not authorized, and use EMS frequencies only authorized for EMS communication. So transmissions throughout the call. Initially, the call comes in via telephone, but may be radioed from another agency. Without prompt and efficient dispatch and receipt of the information, ambulances can be sent to the wrong location. The dispatch records all times according to a 24-hour clock. Time of the original call, dispatched, staging, and then on scene. And the dispatcher gives times after most transmissions. They'll basically say, hey, on scene 21:45. Okay. Many transmissions are between the mobile radio and the ambulance and the dispatcher at a base station. In some EMS systems, simple standard communications are transmitted by pushing a button on a mobile data terminal mounted in the ambulance. We have computers for CAD, the computer-aided dispatch. Our CAD system sends the dispatcher sends the call to our CAD, and then instead of getting on the radio and say, hey, we're responding, we're on scene, blah, 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 we hit buttons on our CAD that tell them when we're on scene and when we've left scene, where we're going, all this stuff. And then carry a portable radio whenever you leave the unit. Medical reports. So report must be given to the destination hospital so it can prepare for arrival. Reports may be radio, verbally, in person, in writing, or in all three ways. Around here, in this area, we typically give a radio report before we get to the hospital. And it's done just on the radio saying, hey, this is what I've got. This is their chief complaint, vitals, and what I've done for him. Okay, it does not have to be like huge, in-depth thing. Just very specific. This is what I've got. This is their chief complaint. This is what I see. You don't have to go into the patient history. You don't have to go into the fact that they broke their knee 5 years ago. It may be irrelevant at that moment. So you're going to use your unit identification and level of provider. Estimated time of arrival, patient's age and sex, chief complaint, a brief pertinent history of the present illness and injury, and any major past illnesses. That last one is more of a verbal report to the hospital when you get to the hospital, because there are differences. There's a radio report and a verbal report. The radio report you give to the hospital beforehand, and then a verbal report you give to the hospital when you get there. So major past illnesses, unless it is pertinent to their problem, then is irrelevant. Mental status, baseline vitals, physical exam. Again, pertinent findings of the physical exam. I don't need to know about every scrape, cut, and abrasion that the patient has. I just need to know, is it still bleeding? Okay. what you did for the patient, if they had a good response or not, and then contact medical direction if required or if you have a question. Typically for you guys don't have to call med control for anything, because there's not a whole lot that you guys do as EMTs that would require med control. When you do contact medical control, you're going to give them the information clearly and accurately. After receiving an order, you're going to repeat the order word for word. If the order is unclear, ask the physician to repeat it, and if the order seems inappropriate, question the physician. Okay? Do not hesitate to question the physician. Verbal report. This is given upon destination. You're going to introduce the patient by name, give a complete and detailed report. You're going to give the chief complaint, history of, that was not given previously, assessment, treatment given en route, and any additional vital signs. Interpersonal communication. So we are going to communicate with all sorts of people involved in this patient's care. So first responders, advanced EMTs, paramedics, home health care aides, and family. You want to speak candidly and respectfully to gather information about the patient and complete any necessary and appropriate transfer of care. Therapeutic communication. So communication techniques learned by experience may be more difficult with those in crisis. Everyone can improve their communication skills by learning effective communication techniques. Use eye contact. It shows interest, assertiveness, attentiveness, and comfort. Be aware of your position and body language. Face the patient at eye level with arms down. Why is that? If we stand over the patient, what does that mean? It means that we are in a position of authority, that we may be looking down on the patient, so we don't necessarily want that. Use language that the patient can understand. Do not use medical terms, okay? And explain procedures. Most patients don't know a whole lot of medical terms, so they're not going to understand what you're saying anyway. So you have to kind of explain it. Use plain language, explain what the medical term is. I've had patients who I ask them if they have hypertension and they tell me, well, I have high blood pressure, or they don't know what it is, and so then I say high blood pressure and they say yeah. So just one of those things. Okay. Be honest. Dishonesty ruins confidence and rapport. Use the patient's proper name. It's a sign of respect, especially with older patients. So Mrs., Mr., those things. Try not to use buddy, pal, partner, everything like that. I do. It's just something that I do. However, we should probably try to avoid it. Listening is important to establish trust. Special considerations: always be compassionate and respectful if the patient has a mental disability, they are visually or hearing impaired, or they have any kind of language barriers. Speaking louder to a hearing impaired patient is only good if you know that they are hearing impaired. Don't assume that because they are older that they have some type of hearing impairment, because they're just going to yell at you. Pediatric patients, come down to their level and be truthful. Don't tell them that it's not going to hurt if it's going to hurt. Okay. The pre-hospital care report, written documentation of what happened during a call. There's several forms: handwritten, laptop, tablet, pen-based computers. We use computers, laptops, and that's what most services use anymore, just because it is easier to track and maintain, and do all of that. So there's software out there that allows us to do a written report on it, and then do a drop or transfer report. We don't necessarily. So for Mercy, we don't transfer our reports anymore to the hospital. It does it automatically. It used to be that we had to go in and fax it to the hospital and blah blah blah. We don't have to do that anymore. It just does it. So the patient care record documents findings and treatment. It conveys a picture of the scene, and it's entered into the patient's permanent medical record. When I say it conveys a picture of the scene, I want to be able to read your report and basically act as if I was there, or feel as if I was there. So the more information you can give me, the better. Okay. I always put in my report where I found the patient and how they were sitting or laying or whatever. So if I come in and my patient's in the recliner, I say, upon arrival, a patient was sitting in the recliner in the living room. Yeah, I mean, that's pretty much my first sentence. Or a patient was found, upon arrival, patient was found laying on the bed in the bedroom, or sitting on the recliner in the bedroom, or wherever they were found, I put it in there. It is a legal document. It can be subpoenaed and used as evidence. It may help the patient win in a case, and it may also be used against you in a case of negligence. It has some administrative data, insurance information, and billing address. And then we also use it for education and research. We use it for clinical research, statistics, continuing education, and to track the EMT's personal experience. When we use it for quality improvement, we do a routine call review. This ensures compliance to standards. It can also reveal providers deserving special recognition. Maybe they caught a STEMI or they delivered a baby or something like that. And it can also reveal opportunities for improvement. NHTSA has more than 400 elements that are required for patient care reports. There's a minimum data set available nationwide, but that minimum data set is required for every single patient contact that you have. Run data includes the agency name, the date, the times, call number, unit personnel, levels of certification, other basic information mandated by the service. You want to use the official time given by dispatch so that all times in the report match. In the patient information, you have name, address, phone number, sex, age, date of birth, weight, race and or ethnicity, and billing and insurance information. Information gathered during the call, so general impression of the patient, narrative summary of the call, the patient's prior aid, past medical history, physical exam, vital signs, ECG reports, procedures and treatments, medications administered, and any other information that may be required, and then transport information. In your narrative sections, there's a few different ways you can write the narrative. You can write it as a SOAP, so subjective, objective, assessment, and plan. That objective information is observable and measurable and verifiable, and then the subjective information is subject to interpretation or opinion, often reported by the patient. So I can see that my patient is pale and diaphoretic. Those are objective information. The patient tells me that they are in pain. So in my report, I'm going to say patient states that he has crushing chest pain. Okay. Chief complaint is the primary complaint as stated by the patient. It's best recorded as a direct quote. Pertinent negatives are important negative findings. So if my patient has chest pain but they don't have any difficulty breathing, or they don't have the pale diaphoretic whatever, then that's a pertinent negative and it's important to note. Okay. Avoid radio codes and non-standard abbreviations. Write legibly and use correct spelling. Again, most people use a computer, so legibly, not necessarily a must, but using the correct spelling is a must. Information that must be read easily and accurately, and the PCR is a reflection of your care. Use appropriate medical terminology, and if you didn't write it down, you didn't do it. Special documentation issues, so legal issues, confidentiality is covered by the HIPAA Act, accountability and security. There's a lot that goes into HIPAA. We talked about it back in chapter 4 slightly. Patient refusals have a high liability. We want to document all details in a refusal of care form. Falsification, so covering up errors or recording something you forgot to do. Correction of errors, mistakes in documentation, and additions. Okay. Multiple casualty incidents, logistical problems for EMS, documentation of information for individual patients may be difficult. Care and evaluation by several providers at different times and locations. It's important to keep information with patients from an MCI scene as long as they move through the system. Sometimes in mass casualty, we miss patients. We label patients wrong. It's something that happens. There's no foolproof system out there, so it does happen. But you've got to just make sure that you are documenting every single patient care that you come across, even if it's just as simple as patient 1 seen for blah blah blah, they were a red. Yeah. Special situation reports. So these are reports that you may file or maybe like an addendum to your patient care report, depending on the service. But exposure to infectious diseases, injury to yourself or another EMT, hazardous or unsafe scenes, referrals to social service agencies, and then mandated reporting issues. Again, these are all forms that you may run into in your career. I think I filled out probably all of them except for hazardous or unsafe scenes. And typically they're not part of the patient care report. They may be attached or have some type of attachment to it, but they're not part of the report itself. So